name is Dr. Lim Zi, and I'm a consultant hematologist based in Singapore. Today, I'd like to share with you data which will show how CAR T-cell therapy has redefined the cure probability in patients with relapsed or refractory diffuse large B-cell lymphoma. CAR T-cell therapy has become the standard of line care for patients in second line with relapsed and refractory diffuse large B-cell lymphoma. This has been built on the back of several pivotal clinical trials, which has given us the data to support the approval. And if you look at it, clinical trials for CAR T-cell have been gone back for a significant amount of time, and this led to the first approval of CAR T-cell therapy in the third line in 2017. Subsequent trials, some of which the data I'll share with you shortly, have led since to a big leap forward, where since 2022, two products have now been licensed for the treatment of diffuse large B-cell lymphoma in second-line therapy. So first, I will share with you data from the ZUMA-7 clinical trial, which looks at patients who received axi-cel for second-line diffuse large B-cell lymphoma. This is a phase 3 randomized clinical study in multiple centers, looking at 359 patients who were randomized on a one-to-one basis. Patients either received axi-cel or patients received standard of care. And these patients received standard of care with chemotherapy, which contained a platinum-based regimen. Patients who responded to treatment were allowed to proceed towards autologous stem cell transplant. Patients who did not respond, however, were allowed to have treatment of choice off trial, and this included receiving CAR T-cell therapy in this arm. Patients' eligibility criteria basically involves patients who had relapsed within 12 months after first-line chemotherapy. The primary endpoints for this study was the EFS, and the secondary endpoints for this were the overall response rate, overall survival, PFS, as well as looking at the safety. So the ZUMA-7 was one of several trials which were looking at the role of CAR T-cell in patients with second-line diffuse large B-cell lymphoma. The important thing looking at all these phase 3 studies is the difference in the patients in the different arms of treatment. So again, when we look at the data from ZUMA-7, where patients on one arm received axi-cel, CAR T-cell therapy, and on the other arm, patients on the standard of care arm received what was perceived to be the standard of care, which is autologous stem cell transplant. Nearly 3 times as many patients were able to receive axi-cel therapy versus autologous stem cell transplantation. If you delve further into the data for ZUMA-7, you can see that this cohort of patients were patients who had the typical characteristics of high-risk lymphoma. Yeah? The age of these patients, more than almost 1/3 of the patients were aged 65 and above. In addition, it was worth noticing that while the criteria was for patients who were relapsed within 12 months of first-line treatment, actually, almost more than 70% of patients had true refractory disease, and a quarter of the patients roughly had relapsed within 12 months. If you look at the other disease characteristics, you can see that patients have high-risk disease characteristics. Notably, most of the patients had stage 3 to 4 disease. They were either double expressors. A proportion of patients, around 20%, also had at least double hit lymphoma. When we look at that primary endpoint, which is EFS, as mentioned earlier on, you can see that the median EFS for the arm which received axi-cel therapy was 4 times better than patients who received standard of care therapy. And if you extended this out to a 2-year time point, the 2-year EFS for patients who received axi-cel was 41% versus 16% for patients who received standard of care. One of the advantages is now we have long-term data for these patients, and you look at patients at 4 years out, the overall survival for patients who received axi-cel therapy was 54.6%, and the standard of care arm, the overall survival at 4 years was 46%. And this was a 27% reduction in death between both arms. And one thing to note as well is that in terms of patients who received the standard of care arm, this included patients who actually went on after dropping off the clinical trial to receive CAR T-cell therapy as well from there. So when we look at the safety profile of axi-cel in ZUMA-7, what we can see is that the safety profile readout is similar to what we have become experienced with in the use of XSL in the preceding Zuma trials as well from there. It's well tolerated from that point of view. Patients can get CRS, but most CRS is manageable. And of note, in this trial, there were no grade 5 CRS events. And this, again, is a reflection I would like to think of the fact that many of the treatment centers have become familiar with managing the potential challenges of CRS even in high-risk patients, and protocols which have now been developed are able to successfully navigate patients in many cases through treatment with CAR T-cell therapy. So one of the things that we were able to look at in terms of the ZUMA-7 trial was certainly whether, again, the lines of therapy affect the outcomes and the efficacy of CAR T-cell therapy, and in this case, XSL. So we've seen the headline figures, which is basically patients in second line treated with XSL. You have an overall response rate of 83% and a CR rate of 65%. But remember, some of these patients in the standard of care arm were later on able to receive XSL. And we can see in this cohort of patients, we still had success, albeit lower than patients in the second line. So 57% of patients still attained the overall response rate, and 34% of patients achieved a CR. Again, this shows that CAR T-cell therapy is effective both in the second line and third line of therapy in this high-risk cohort of patients, but certainly it validates the use of this treatment earlier upfront in the second-line therapy. So where are we? So let's focus on ZUMA-7 and the XSL. We've made huge strides. For many years, if you look at the original Palmer study, the gold standard of treatment for patients who had relapsed or refractory diffuse large B-cell lymphoma was an autologous stem cell transplant. We now have taken a leap forward with significant clinical trial data to show that CAR T-cell therapy given a second-line therapy setting shows superior outcomes from there. And importantly, it's highly deliverable too. So one of the key things to note, unlike autologous stem cell transplants, which are not necessarily accessible to all patients, patients who are considered for CAR T-cell therapy, in most cases, we have a high incidence of pushing them through with success in manufacturing and delivery of the CAR T product. Now I'd like to share with you details of another clinical trial, phase 3 study, which shows the role, which again demonstrates the role of CAR T-cell therapy in second-line DLBCL. And this is the TRANSFORM study looking at another CAR T product, which is liso-cel. Again, this is a phase 3 randomized clinical trial again, multi-center, looking at a smaller number of patients, 184 patients. Again, patients who were relapsed or refractory disease within 12 months after first-line treatment. Patients in this case were randomized again between either liso-cel or the standard of care, where they could receive an autologous stem cell transplant. One of the differences in this study is that patients who could not receive an autologous stem cell transplant or who failed on it were crossed over within the clinical trial to receive liso-cel instead. So again, similar to ZUMA-7, you can see the demographics of this study. There's a reasonable proportion of elderly patients in this cohort, and the median age is high. Majority of the patients enrolled on this study were again more likely to be refractory to first-line therapy than late relapses or early relapses. And these patients had high disease characteristics again. So again, if you look at the primary endpoint of the TRANSFORM study, again, use of CAR T-cell therapy, again, liso-cel in this stage showed a higher, significantly higher median event-free survival. And when again stretched out 18 months in this case, your EFS was 52.6% for patients who received the CAR T therapy. When we look at the TRANSFORM study, we can see that again, liso-cel resulted in a superior overall survival when compared with patients who received standard of care treatment. However, in this study, liso-cel's overall survival was not shown to be statistically significant. Again, when we look at the safety profile of liso-cel in the TRANSFORM study, the data is comparable to what we've seen before in ZUMA-7. Taking into account these two pivotal phase 3 studies, looking at the benefits of CAR T-cell therapy in second-line diffuse large B-cell lymphoma, the guidelines from NCCN have changed in terms of how we use these patients, use CAR T-cell for treating these patients in the second-line therapy. Right? What the key thing now is that we look at a timeline in terms of how soon patients may relapse after treatment in terms of determining whether they may be suitable for therapy. Because it is clear that patients who relapse within 12 months after first-line therapy are the ones who benefit most for CAR T-cell therapy. And these patients should definitely be considered upfront for CAR T-cell therapy where possible. So taking all this information to hand, if we look at where potentially patients may be when we treat them with diffuse large B-cell lymphoma, we know that 40% of patients either have relapse or have refractory disease after DLBCL. Yeah? So patients who relapse after first-line therapy, we will want to look at the timeline in which they relapse. We know that approximately 70% or more patients actually relapse within less than 1 year. And these patients should be considered for CAR T-cell therapy if they are suitable. So we know that approximately 20 to 30% of patients may have late relapses after first-line therapy. Yeah? So of these patients, if they are fit and eligible, they should be considered for more chemotherapy and potentially autologous bone marrow transplant. However, not all of patients are fit for this, and probably only 50% of these patients may be suitable. But if you whittle down the numbers, as we showed previously, actually only probably 10% of patients will benefit from autologous stem cell transplant. So probably half the patients with late relapse may still be considered for CAR T-cell therapy or similar therapies from there. So in summary, I think the timing of relapse is still the key consideration for patients who have relapsed after first-line treatment, and the patients who benefit most are patients who relapse within 12 months after first-line treatment. Okay, so having taken all this into account, how do we navigate our patients with diffuse large B-cell lymphoma towards CAR T-cell therapy? Yeah, it's a journey. It's a long journey which requires a lot of coordination, and there are several factors which we have to bear in mind. Yeah, one, patient selection is important, and factors which may prompt us towards selecting these patients include some of the features of disease characteristics I mentioned in the second part of my talk. So early identification of these patients is important. The second part of it is how we prepare patients for CAR T afterwards. So part of it is counseling the patients and mentally preparing them that this may be an option. The second thing is early discussion with a specialist center in terms of preparing them for referral for CAR T-cell therapy and discussing the taste to think about how we can optimize our patients along the way. Once patients are selected and we think that they are going towards CAR T, we then have to prepare them for apheresis. And again, there are criteria that we have to consider for apheresis in terms of certainly potentially washout periods of certain drugs before they go through apheresis. And once patients are harvested, for example, for axi-cell, there's a duration between harvesting of the cells and infusion of the cells. And we have to consider a bridging strategy for these patients again. And this involves often multidisciplinary discussion between the primary and the specialist center and radiotherapists in terms of what's the best line of treatments we offer for these patients. When we infuse the CAR T, again, ideally it should be in experienced centers which are well trained in both the infusion of the CAR T-cell therapy, as well as being able to monitor patients through the treatment and handle the safety issues, including CRS, which may happen after infusion. And it's important that you have a setup which is experienced in managing CAR T, so both the physicians, be it the hematologists, the intensivists, the neurologists are all trained and experienced in managing the complications of CAR T-cell therapy, and you have a standby intensive care unit in case patients deteriorate. Yeah. And finally, even after patients go through the initial phase of CAR T-cell therapy, hopefully in many cases the patients will return back to their primary physicians, and that's where again coordination and a lot of communication is important to ensure that patients have the adequate long-term follow-up in terms of disease monitoring, in terms of monitoring for potential side effects from that point of view, and also in terms of strategies in case other complications arise along the way. Okay, so thank you for listening in. And just to recap, I'd just like to re-highlight again and reiterate the approach that we should take when we look after our patients with relapsed or refractory diffuse large B-cell lymphoma, and the considerations when we consider them for CAR T-cell therapy. So recur. So thank you very much for listening, and I hope you found this useful.